Next, I call upon Dr. Ganga to speak about imaging in orbital trauma.
Thank you, Raghu. Compliments to you for putting the trauma course together, and compliments to each one of the speakers here. I'm so happy that trauma is now becoming a standard topic which is being discussed and presented in these international meetings. So I'm going to talk a little bit about shadows. Shadows is we're talking about imaging, and that's interpreting the CT scans, which is imaging of choice for if you're doing orbital and orbitofacial trauma. I bring you greetings from Asia Pacific Ophthalmic Trauma Society. So those of you who are not members of your Ophthalmic Trauma Society of India, there was a general body meeting yesterday where there's a constitutional move made that the Ocular Trauma Society of India is going to be relabeled as Ophthalmic Trauma Society of India, because we are ophthalmologists, not ocular specialists. So we remember that while there are two orbits on the face, they are a most important component of the face. So by default, we now call it orbitofacial trauma. There are lots of pieces of knowledge in the literature, and if you read the old textbooks, there are certain anatomical descriptions or diagrams which are present, which are not practically or functionally right. So that's why you have to know your traditional anatomy, but you also have to try to know what is the three-dimensional concept of the human anatomy and the orbit, which Raghu talked about as well. We are seeing more and more of what we're doing. Orbital surgery is no longer a blind surgery. You're digging something inside the orbit, you don't know where you are. We're going into a digital era where you're using the DICOM data now to do all your diagnosis, treatment planning, postoperative analysis, so forth. And more importantly, taking a book out of the retinal surgeons, what is the principle of retinal detachment surgery? Put the retina flat, do an anatomically correct reconstruction, then function will follow. In the past, we were compromising a lot of this in the name of function, thinking I don't know where I am in the orbit. That no longer is an excuse. And these are my disclosures. But more importantly, in the Atlas of Orbital Imaging by Guy Ben, Simon, Daphna, and Gal, we have certain chapters purely on imaging and trauma, preoperatively, intraoperatively, postoperatively. So beware shadows. So if you look at this is what CT scans is all about. But actually it can be something else. So it does not directly translate into what you see in clinical practice, but it gives you an idea of what to expect when you go in. And I encourage all my residents and fellows, look at the scan, think of what you're going to see inside, go to your dissection, pay attention, go back after the surgery, look at the same scan again, said what correlated, what did not correlate. That's very important. These are the various imaging modalities of choice. We no longer use X-rays. The only purpose of an X-ray is an emergency room in a general hospital to screen for not all foreign bodies, radio-opaque foreign bodies. Remember, there are other foreign bodies which can be missed. So CT scan by default is imaging of choice. You have to view them in all planes, axial, coronal, sagittal. It's not enough to view only one cut. And you also view them in the bone window for fractures and foreign bodies and soft tissue windows. And here are examples of patients in the coronal cut on the left, where you can see a comminuted displaced zygomatico-maxillary complex fracture, ZMC fracture, which is also an orbital fracture. I still have ophthalmologists who come and tell me, I have a patient who's got a ZMC fracture but not an orbital fracture. That's not true. The zygoma forms the lateral wall of the orbit. Only the isolated arch fracture is not an orbital fracture. Otherwise, by default, all ZMC fractures. But if you pay a little close attention to the top, the roof, you actually have a skull-base breach as well. So it's not an isolated ZMC fracture. And that's why you looking at the scan yourself and not the report is very important. The middle image, apart from the bony structures that you see a flat tire sign, a deformed globe. This way, again, if you're not looking, pay attention to the soft tissue, you'll be missing these scans. And of course, on the slide right, you see the radio-opaque foreign body. So how do you know whether it's plastic, metal, so on and so forth? Akshay, how will you know that foreign body there is a plastic, metal, wood on a CT scan? Hounsfield units, the H word, not the word, okay? You can use a Hounsfield, which is available in a PAC system. You should be able to do it. So CT scan, bottom line, is the imaging of choice. It's used for diagnosis. It's used for management. And don't forget, if you're the ophthalmologist or cataract refractive surgeon, if you don't refract your patients postoperatively, it's inadequate care. Likewise, you should be the ophthalmologist, should be viewing these patients postoperatively, both early, when you placed implant right or not placed implant right, to counsel for learning for yourself and counseling the patients. And when you're using bioresorbable implants, do late postoperative imaging. Typically, I do 15, 18, 24 months to show the bone has healed and the implant is gone, so they don't have to worry too much about as well. What are the radiological signs? We are familiar with the obvious cortical disruption of the bone or gross herniation of contents as radiological signs. But remember, there are subtle signs in the CT scan you want to look for. For example, an opacified maxillary sinus. Remember, not all opacification is blood in the antrum. So you can be mucocele, polyps, so on and so forth. So the kind of leveling that you see within the maxillary sinus or diffuse comminution of the adjacent bone and opacification of the ethmoid sinus, for example, are the subtle signs you're looking for. And every time you see an air in the orbit, air pocket in the orbit, not in the anterior superior fornix or inferior fornix, but within the orbit, or air in the skull base, intracranial frontal fossa, by default there is an orbital fracture, and usually it's an adjacent paranasal sinus. So what are the landmarks you're looking for? Yes, you like a picture, you're looking for a frame, so that's what you'll be reconstructing when you're doing complex fractures. Once you look at the frames, then you're looking at the walls of the orbit. Starts off as 4 walls in the front, and as you go back, it becomes only 3 walls. The floor and the medial wall become a continuum, and that's where the customized designing of the implants are going to be important. Raghu talked beautifully about the buttresses, which are going to be the pillar points at which, if it's not broken, you're going to rest these implants, and if it's broken, then you have to reconstruct it. That's where the 3-dimensional anatomical prefabricated plates comes in. We'll talk a little bit about the angle of intromedial orbital strut. This is an AIOS meeting. AIOS, in my opinion, stands for angle of intromedial orbital strut. Okay? And the sphenozygomatic suture, which is the lateral buttress, which is got to talk about. Again, we're doing lateral wall reconstruction. Alignment of the sphenozygomatic suture gives you an intraoperative confirmation whether you've done a good job or not. And of course, the place you really want to stay away from is the orbital apex. But when you see a ptosis postoperatively, it's not all hematoma. You can have superior orbital fissure syndromes which cause a ptosis, which is going to get better on its own. So that's how you see these patients. A clinical patient with a clinical sign on this outside, but what you should be looking is with X-ray glasses or CT glasses, seeing what's really going on inside. Textbooks get this wrong. Remember that the posterior wall is not, or the floor is not one straight line, or even the medial wall is not one straight parallel line. It bulges into the orbit, which is what gives you the projection of the globe. And again, you don't get this right with the anatomical reconstruction, you get postoperative enoughthermus. This is the infromedial orbital strut, which is a solid bone that's at the junction of the floor and the medial wall. You want to pay conscious attention to it, whether it's disrupted or not. So in the past, when you did thyroid orbital decompressions, we were heroically removing that strut, thinking I'm going to do a good decompression, but that allowed the globe to sink back inferiorly and medially and posteriorly into the sinuses, causing globe dystopia. So again, paying attention to the strut, and if it's broken, fixing it, and it's not broken, respecting it and placing the implants, as you can see on the various bony edges, as you see in the image below, is very, very important. And this is the angle we are talking about. Again, if you have a unilateral fracture, the contralateral orbit is a beautiful sign. It's how, again, in the past, when you're doing rural cataract surgery camps, when you do a biometry, you do a biometry at the other eye, and that usually correlates. Of course, there's anisometropia and so on and so forth. It's a guideline. It's not a 100% perfect symmetry. By measuring that angle that you see on the contralateral side, helps you even pre-bend these implants ahead of time before you even start dissection. You're not doing any guesswork intraoperatively. Reduce the contents atraumatically, stick it inside, verify it's in the right place, and get out of there. Yeah, so that saves you a lot of time as well. So how do you request CT scans? We no longer request CT orbits. It's always CT face and orbits. You don't need contrast, obviously. It's a post-trauma case as well. The other disease where you do non-contrast study routinely is thyroid eye disease. Again, you don't need that. So this is where, again, we clinicians should be directing the radiologist rather than the other way about. Of course, every other condition, inflammation, tumors, you offer contrast, yeah. So we now do image guidance surgery protocols, which are sub-millimeter protocols, which gives you a more detailed data based on which you can do your treatment planning, intraoperative navigation, 3D reconstruction, so on and so forth. So you have to demand this of your residents. So I can understand when people say you order a CT scan. I said, no, we request a CT scan. But if the other guy on the other side is not receptive to what you do, yes, go ahead, order the CT scan. You should order and demand what you really want and look at, get the DICOM data. So gone are the days we're looking at films. We're using DICOM data with various data DICOM readers as well. And here's a beautiful rendering of bone windows, axial, coronal, sagittal, showing the emphysema and the axial cut. You can see the disruption of the medial wall itself. Not too much details of soft tissue. Coronal scan showing the floor, medial wall, and then, of course, the floor itself, and the various DICOM readers as well. So quickly touching upon a few other things that I want to show you as well. CT scan is beyond blowout fractures. Sadly, I wrote a chapter was coming out of the American Academy of Ophthalmology Basic Science chapter. I wrote everything about fractures, chop, 70% gone. Then I wrote about floor and medial wall fractures, chopped. They want only to hear about floor fractures. So believe it or not, true story, okay? So combined floor medial wall fractures and isolated medial wall blowout fractures only form 30% of the component. Rest of them are complex fractures. You can contact any of our faculty here later on. Examples of pure orbital blowout fractures, an example of complex cranio-orbitofacial fractures. This is a firecracker which took off from the bottle, lodged in the orbit and exploded. Yeah, and of course NOE fractures are still your domain and is very important to address the lacrimal system. Examples of pure blowout fractures. When we came up with A, B, C, D, E, F, G, H, I, and the D is a very important letter because scan helps you describe the degree of displacement and so on and so forth. So those of you who are interested in deciding, am I going to fix these fractures or not, follow this principle, and you more or less know at the end of your scan and clinical assessment whether you're going to fix this patient, how are you going to fix the patient, who are you going to fix the patient with, are you going to use bioresorbable implant, are you going to use permanent implant? That's something very useful. Here's an example of where there is an adult. C stands for a complex fracture, D stands for significant displacement, G stands for associated globe injury, and the I means I'm going to intervene for these patients. So something that we're teaching alphabets itself. So other radiological signs, look for entrapment. Again, entrapment is a clinical sign, not a radiological sign. This was missed by the radiologist. Nasolacrimal duct and superior orbital fissure area. One more minute to go. We also use a DICOM data for intraoperative navigation and treatment planning. So it's becoming a mainstay, it's becoming a quality of care for endoscopic sinus surgery. It's a matter of time before it becomes quality of care for complex fractures or revision fractures. And you can navigate to various landmarks before you place the implant, after you place the implant, and if doing postoperative analysis as well. These are examples of well-reconstructed fractures where, again, a combination of exposure, choosing the right implant, pre-bending the implants, intraoperative navigation, and postoperative confirmation. So there, you can also use a DICOM data to do 3D modeling and pre-placing these implants. Value of imaging of this quote-unquote lid laceration, which was left until tomorrow to be fixed by a plastic surgeon. X-rays did not show anything, and the CT scan gave away there was an open globe injury, which was missed both by the ophthalmologist because the child was not cooperative. So learn to interpret your scans, look for soft tissue signs, look for occult head injuries as well. Remember, traumatic brain injury is getting a lot of attention now, and postoperative imaging. So I will leave it at that. So in the interest of time, I'll probably stop right there saying that, number one, orbital fractures are not pure orbital fractures. It's only in 30%. Vast majority of them are orbitofacial fractures. Make sure you request appropriate sequence for the imaging. Make sure you read your scans yourself. Do your treatment planning. If necessary, work with your craniomaxillofacial colleagues so they can deliver good care for the patients. Thank you, Raghu, for your invitation. And please contact any of the faculty anytime.